Hip dysplasias, abnormal development of head leading to lack of inappropriate coverage or containment of the head in the shallow acetabulum, which is deficient and has poor bone quality, leading to uneven distribution of forces. Pathoanatomy, femur, coxa valga, and increased anteversion, acetabulum version, retroversion, and being shallow. Crow classification is important in the relation of teardrop, draw a teardrop line, and the degree of proximal migration of femoral head is measured. If Crow 1 is less than 50% subluxation of femoral head, Crow 2 is 50 to 75% of femoral head subluxation, Crow 3 is 75 to 100, and Crow 4 is dislocated. Heart of Helicadus classification, type A is dysplasia, type B is low dislocation, where the fall acetabulum is still connected to the true acetabulum cavity. Type C is high dislocation, and superiorly a false acetabulum is created. I will do X-ray. X-ray can show crossover sign. It's important to measure lateral central edge of Weiberg, which is less than 20. This assess the superlateral coverage. Useful after 6 years, a vertical line drawn to the center of femoral head and a superlateral margin of the acetabulum normally is 25 to 40. Increase in pincer lesions and protrusions and decreases in dysplasia. Acceptable angle of tonnus is a sorcel angle, so a line is drawn and line parallel to the sorcel is drawn at parallel to the interteardrop and angle is measured. It should be more than 10 degrees. Acceptable angle of sharp, this is a sympathetic abduction angle, a teardrop line is drawn and then angle from the lateral edge of the acetabulum. A normal is 33 to 38 degree. In pediatric use, try radiated cartilage instead of teardrop. And protrusio femoral head is lying medial to ilioischial line. Coxa profunda, floor of the acetabulum is medial to the ilioischial line. CT scan is advised, can be done. Regarding management, it can be acetabulum or femoral osteotomy, arthroscopy, arthrodesis, and total hip replacement surgery. Regarding the total hip replacement surgery, I would like to template the hip. Critically, it's restoring the anatomical center of hip, anticipated hip cup coverage, and addressing ligament discrepancy and deciding femoral size, stem size, and designs. Great trochanter is small, displaced posteriorly, risk of sciatic nerve injury and dislocation is increased 10 times. Lengthening, if needed, 4 centimeter is a cutoff. Regarding the acetabulum, true acetabulum identification is important, can be aided by intraoperative X-rays and drill holes into the acetabulum medial wall. Acetabular coverage by bulk femoral head autograft and allograft, oblong cup or tantalum augments. Cup positioning can be anatomical or non-anatomical. Regarding anatomical, facilitate lengthening, restore hip center, better hip function, reduce GRAF, better bone stock, greater traction injury to the sciatic nerve due to lengthening, and subtrochanteric osteotomy may be added. Non-anatomical, it's high hip center, easier, no bone graft needed, no femoral osteotomy needed, early loosening is a chance. The GRF forces are shear forces, so high chance of loosening, small acetabulum component is used, revision is difficult as bone stock is not restored. Sanchez-Sotelo uncemented cup augments with screws gives better result in DDH. Cortiloplasty is basically a concept where femoral head wall, femoral medial wall of the acetabulum component is fractured within the iliac crust bone. So acetabular component is fractured, medial wall is fractured. Regarding the femur side will be narrow, it will be marked anteversion of the implant, and neck cut and positioning will be difficult. Derotation or subtrochanteric osteotomy may be needed to place the cup in the orientation. Consider if anteversion is more than 4 degrees. Another option would be using modular stem and use of custom-made femoral stems. Subtrochanteric osteotomy indicate if more than 4 centimeters shortening is done because the risk of sciatic nerve injury is increased for more than 2 to 5 centimeter lengthening. Various studies have been reported. Hydrophilicatus A and B, acetabulum problems, hydrophilicatus C, femoral problems. This needs metaphyseal, diphyseal stems, for example, SROM. Tracing acetabulum and finding tal is difficult. Osteotomy below the sleeve. Keep simple osteotomies. Use cerclage prophylactically. Dysplastic hip, one option is ARR, acetabular reinforcement ring. ARR, acetabular reinforcement ring. If dysplastic hip you are doing, trochanteric tightness, uh, especially in Crow 4, if there is infratrochanteric tightness, you need shortening. If supratrochanteric tightness, needs soft tissue releases.